Well, let's get going. Uh, got some interesting cases here for you guys. So somebody want to give this first one a go?
Good morning. I can take this first one.
Okay.
So it looks like a punch. I'm favoring neoplastic, but it looks benign to me. It's pretty well demarcated, like I could draw a line around it. It
Good.
looks the stroma looks relatively uniform throughout, and it's pretty symmetric in shape. So that's why I'm
Yeah.
favoring benign.
And those are all exactly good reasons for favoring benign. So yeah, absolutely. It's not a real small lesion. It actually probably is an excisional biopsy, but it's
Oh,
not it may have just been in a total excision from, removing the entire thing. Maybe they thought it was a cyst or something like that. But yeah, it's very symmetrical. It's got like 3 or 4 little aggregations. So when you get that, sometimes just look at each one of the aggregations independently, and each one of them looks small and symmetrical and well circumscribed, et cetera. Um, totally correct about being able to sort of draw a line and right around the lesion. There's no sort of spreading of the cells between the collagen bundles at the periphery, anything like that. So yeah, I agree. It looks totally benign. So the next step would be, what kind of differentiation do you think it is, epithelial or non-epithelial?
I think epithelial.
Good, yeah, epithelial. Really, so when we do this exercise at low magnification, we're just kind of looking to see if it looks more kind of like a spindle cell process or more um, like a solid lesion like this. So it's almost certainly going to be epithelial. And the next thing we do is ask ourselves what kind of differentiation it's exhibiting. So once we've got it into the epithelial category, there's not a ton of different kinds of epithelium that exist in the skin.
I was favoring maybe like an adnexal structure.
Okay. Now we have several different adnexal structures. So yeah, it's more possibly adnexal. It's not just like stratified squamous epithelium we're looking at here. I agree.
Mhm.
Um, which adnexal structures are we thinking about? Are we thinking about something like maybe these kind of adnexal structures?
Yes, like a eccrine glands or apocrine glands.
See? Yeah, I agree. Probably apocrine or eccrine. Another possibility might be kind of a primitive follicular
Mm,
differentiation. This one doesn't really even have many hair follicles in the entire specimen, interestingly enough. Here we go. There's a follicle up here. So if it's possible, it could be toward the matrical epithelium of a follicle, at least in part, because that can give you kind of these basophilic structures. This side over here, it's got a little more kind of tears in it, so I didn't focus on that. But see, it's kind of got a vertically oriented teardrop sort of shape to it. That's
yes.
also a sign of benign, if something is kind of vertically oriented, just as an
Mm.
interesting sort of clue at low magnification. Okay, so I agree. It's probably adnexal. Could be maybe follicular, maybe eccrine or apocrine. And if you look at higher magnification, now we can kind of maybe be a little bit more specific.
Mhm. So will we see some ducts or duct-like structures?
There's a duct. So that
Hmm.
would probably put us maybe into the eccrine or apocrine category. Obviously, if it's apocrine, we're going to be looking for decapitation secretion. Um, really don't see much of that in here. We've kind of got some cells that are a little bit pale, a couple of the cells that are more small and round and cuboidal. So when you see that combination, that kind of makes you think more likely kind of an eccrine lesion. Now, there's one other finding in this lesion. Okay, so you know a little bit about adnexal tumors already. We've had some of those in our unknowns. Um, what, which ones would you possibly think of here based on what we've seen so far?
Looking at like this blue structure in the dermis makes me think spiroadenoma
Yeah,
or
it would make you think of spiroadenoma first, wouldn't it? It would.
Mhm.
Now, what's what's wrong with it for spiroadenoma, though? What's not so great about it? It's missing a couple of things, isn't it? What do you usually see within the sea of blue cells in a spironoma?
You can see, I guess, I'm not exactly sure what the question is. Maybe like lymphocytes or other
Well, there
types
are
of.
some lymphocytes in here, but actually what you usually see are these little pink droplets in there. Go back and take a look at a spironoma, and you'll see it's got all these little tiny pink little droplet structures within the lesion. It's really pretty characteristic. We see that in spiranomas all the time. We
Mhm.
don't have that here. So that's a little bit funny. And usually spiranomas, you're lucky if you see any ducts in them. It's pretty uncommon. This also has a slightly different stroma. It's got this, this fibrous stroma here. And a spironoma, you usually don't see much of that. So it's a little different than a classic spironoma. It seems like it's maybe closest to that.
Mhm.
It's not perfect for it. And so there, you did say that there were also some other cells in here. And this is a rare tumor that you're probably not going to encounter on the board examination, but at least you will have heard of it. And if you encounter it on some other situation like the Dermpath bowl, you'll say, aha, I've seen it. I know what it is.
Um,
This is the clue. All of these lymphocytes sprinkled throughout the lesion. And notice how they're not out here. There's no lymphocytes here, but they're all in here, which is kind of funny. Why are they sitting in the middle of this neoplasm, benign neoplasm? It's not trying to, develop any immune response to a cancer or anything like that. It's sitting in the middle of this thing, and some of them are relatively numerous in some areas, like here. You may not have heard of this tumor. It does look like an adnexal tumor. In fact, people kind of argue about what the epithelial component of this thing is. But what this is a cutaneous lymphadenoma. Lymphadenoma. It's a rare tumor. It doesn't look exactly like a spironoma, as I mentioned before. It's probably some kind of follicular tumor that may be kind of a hybrid between maybe an apocrine and follicular, because the apocrine gland and the follicles, they both come off the same embryologic onlaga. So that may be what the underlying tumor is, but they get this aggregation of lymphocytes within it, which is fairly characteristic. So if you see something that looks like a spironoma, and then you start looking and say, well, it doesn't have the pink droplets in it. It's a little bit funny, and sometimes you'll even see features of cylindroma coupled with spironoma, especially if you're dealing with somebody that might have Brooks-Spiegler. And then you
mhm.
say, it's not perfect for a spironoma. It's got all these lymphocytes in it. Think about lymphadenoma.
Okay.
Think about lymphadenoma. It's a pretty rare bird. We don't diagnose it very frequently. We don't see it very frequently. And of course, clinicians have zero clue as to this. They have no idea what they're dealing with. And they usually think these are cysts. So whenever a clinician encounters an adnexal tumor in the dermis, they feel like cysts. They're rubbery. Of course, a spironoma is one of the painful tumors. This lesion is not painful. And they think it's a cyst, and they might just do something like this, like maybe a punch excision or whatever, try to get rid of the entire thing. So
Mhm.
that's cutaneous lymphadenoma. Now, the other kind of interesting sort of, if you read up on this, um, it's in the family of other entities where you get a lot of lymphocytes plus epithelium. And another entity that Ron Barr, he actually wrote about this back a long time ago, really good dermatologist out of UC Irvine, really good guy. He talked about the dermal thymus tissue. So like you can get pseudolymphomas and lymphoid lesions of the skin. Well, sometimes you can actually get ectopic thymus, usually in the head and neck area, kind of like you get branchial cleft remnants and things like that up there. You can actually get thymus tissue, and that gives you epithelium. You can get Hassel's corpuscles and more squamous type epithelium plus lymphocytes. So there's kind of spectrum of entities where you get epithelial components and lymphocytes being part of the actual tumor. So they're actually, the lymphocytes here aren't just, they're not coming in to try to wipe out the tumor. It's thought that they're actually part and parcel of this entity which may be somewhat analogous to what happens in the thymus gland, where there's epithelium, but there's also T cells there.
Mhm.
Okay, very good.
Thank you.
You're welcome. All right,
Hey, good morning, Dr. Cockerell. I can take this one.
let's see if I can get it oriented for you here. You gotta have a steady hand with this stupid little thing here. Here we go. Okay.
All right, so we're examining here a punch biopsy.
Yeah, these are great examples of good biopsies for you guys this morning. These are large chunks of tissue, not the usual fingernail biopsies that kind of go about this far. We got a nice big piece, and that's what you're going to get on the boards too, by the way. They're not going to give you little garbage things. They're going to give you things like this that you can sink your teeth into. So,
All right, so a nice 8 millimeter to millimeter punch. So the this is on hair bearing region.
good.
See some sclerosis, so I'm favoring a little bit older patient, maybe scalp, maybe face.
Yeah,
And then
good.
I suspect this is a neoplastic, and so I see in the dermis. So the epidermis is normal, and in the dermis there's this nodule in the center, and a band of infiltrate that extends to the beyond the left margin of this. And then in terms of whether it's benign or malignant, I can't fully assess whether it's benign because it appears to extend beyond the left side of the biopsy. In terms of well circumscribed, let's say the specimen on the rightmost portion, if you were to zoom in on it, I can see something that resembles something of a follicle with these uh, um, pale circles, which are in the wrong location. Actually, they should be in the center of that structure, but they're on the periphery. So altogether, I'd be in favor of a malignant neoplastic process.
Okay, good.
Lymphocytic, but and then I would favor B cell instead of T cell because of its location in the dermis.
I think this is a lymphoma then.
Yes, I think this is probably a primary cutaneous B-cell lymphoma.
Okay, good. Now you pointed out several things at low magnification. That's why I'm not going to high magnification just yet. But notice, first of all, there's no involvement of the epidermis. It's relatively deep, so it's kind of bottom heavy as opposed to top heavy. So if this were a pseudolymphoma, you would most likely see inflammation all the way up here, and more of it would be here than here. So this is like, this is a submarine. This is beneath the surface of everything. That's not a good finding when you see that, number one. So that's good. You pointed out that it really wasn't very well circumscribed. This you got a nodular aggregation over here, but then you got all this sort of diffuse involvement of the dermis and even down into the subcutaneous fat. So those are all signs that this is not a well circumscribed process. So at low magnification, this would be, red flags would be flying when you see something like this. And then you also pointed out it was very basophilic. And so when you see something that's basophilic like this, now you jumped immediately to the diagnosis of a lymphoma, but what else is in the differential diagnosis of these kinds of cells here?
Oh, I don't think it's this, but it could actually have been a neuroendocrine tumor.
Good, good. That's what I wanted you to think of. Is so when you see something that's basophilic at low magnification like that, you say, well, it could very well be lymphoid, but let's make sure it's not neuroendocrine or some other poorly differentiated small blue cell neoplasm, especially if this were a young person, a child, for example, neuroblastoma, Wilms tumor, those kind of things. Blue is bad, especially when it's not well circumscribed in something like this. So we'd be concerned about this. Now, it's kind of got an interesting finding. I think you did point out rightly that it's got this nodular aggregation here with these paler cells here that do look like the cells of a germinal center. So I do agree with you that's a finding that we see commonly in cutaneous B-cell lymphoma. But what about this pattern down here? Is this more commonly seen in cutaneous B-cell or not here, this pattern?
I don't know the answer to that.
Well, the answer is no. It's actually more commonly seen in T-cell lymphomas, paniculitis like T-cell lymphoma, those gamma delta T-cell lymphomas, that they tend to involve the subcutaneous fat, and they give you kind of a pseudopaniculitis. So these lymphomas, I know a lot of guys love lymphoma pathology, and my hat's off to them. That's great. I love Joanne Guitar, and I love guys that like lymphomas, but I hate lymphomas because they don't read any textbook. I mean, you almost have to do special stains and flow cytometry and all this kind of stuff, because you'll see something like this, and then lo and behold, you'll see, well, there's a B-cell, there's a T-cell pattern. It's involving the paniculus. That's uncommon for cutaneous B-cell lymphoma. So, and then sometimes you'll see a B-cell lymphoma that looks like mycosis fungoides, or you'll see one that looks like classic MF, and you do gene rearrangement studies, it's got a B-cell rearrangement and a T-cell gene rearrangement. So, what do you do with all that stuff? So, and then you'll see something that's clonal, and it's a small papule, and but guy's got nothing else anywhere else in his body. So, these things just, there's like whether these things really behave cancerous or not is largely dependent on the host immune system. And I'm not sure that we can just look at something and say, this is a lymphoma and the patient's going to die from it. It just doesn't seem to work that way. So that's why I don't like lymphomas. They don't even have a textbook that they read, I don't think. But you're right. When you look at this looks really good for a cutaneous B-cell lymphoma. And you said primary. Now, why did you just jump to primary just out of curiosity?
Oh, a couple of reasons. There's no involvement with any kind of vascular structures.
But do these have to involve vascular structures? They don't. They just, these B cells are just sort of circulating through our body, and they get in your skin, they set up shop, and they don't have to actually metastasize in blood vessels like a melanoma, for example, or like a breast cancer, something like that. These things they're circulating throughout your body. The neoplastic lymphoid cells get in there, and they can kind of then recapitulate the lymphoma that's going on in the lymph node. So I wouldn't be 100% sure that this is primary. In fact, I think when we diagnosed this case, we suggested that they make sure that it wasn't something that was coming from another site. Now, you're not going to need to get into BCL2, BCL6, all these other stains, CD10, et cetera, that can document whether something's more likely to be benign or malignant. Probably the only case where you might get into that is maybe an ALK stain, which we might talk about that a little bit later. But in this kind of case, we would just, we call it a lymphoma. And I think if you see this pattern with this sort of inside out germinal centers that you quite rightly pointed out, that would favor a follicle center cell lymphoma. Now, what's interesting about follicle center cell lymphomas is they can be comprised of lots of these centrocytes. So the whole lymphoma can be this, or they can be comprised of the cells that are on the outer rim of the normal lymph node that are the smaller lymphocytes here. So they can be mostly those with relatively few germinal centers, and they're not really true follicles anymore, or they can be mostly just these cells, kind of like are going down in the fat. So we don't see any of those germinal center-like structures in the fat area that's involved. Maybe a little bit here, but in some areas we don't really see it much at all. So it's an interesting pattern. I think this guy actually did have a systemic lymphoma that spread to his scalp. He had a known lymphoma, and this was kind of a secondary involvement. Usually when we see primary involvement, you see these large kind of nodular, and they're sort of like teardrop-like aggregations, kind of like that lymphadenoma that we saw before. Usually you don't get fat involvement, and they're usually, the individual aggregations are kind of well circumscribed, because these lesions are super low grade when they're primary in the skin. In fact, these guys probably need to be kept away from oncologists. We don't want them to get on CHOP and MOP and all these dangerous chemotherapeutic agents, because these things do very well, often with just surgical excision or intralesional steroids. You want to follow them, because they can pop up with a lymph node later on down the line, or they can pop up with more than one lesion. They may need to end up in the hands of an oncologist, but you don't want to get too aggressive when they're just primary cutaneous, because they can really respond very well to conservative therapy. So very good, excellent. The good news is you're not going to need to become a lymphoma pathologist for the board. I think that if you see this pattern, deep involvement with this inside-out germinal centers that you quite rightly pointed out, you want to think about a lymphoma that favor that versus a pseudolymphoma, which would be more top-heavy when it have eosinophils and other inflammatory cell infiltrates. If you see the paniculitis pattern, think about that T-cell paniculitis like T-cell lymphoma. They might ask you something about that. Okay. Now we get something interesting.
Hi, good morning. I can take this one.
Okay, great.
This looks like maybe the shape is irregular, so maybe an excisional biopsy.
Okay.
We noticed that it wasn't like normal epidermis. We thought maybe it had some GI mucosa in it.
Okay, what about this area?
The top. I think that is like skin.
Yeah.
That is
Good.
like epithelial, like skin epithelium.
Can you tell which part of the body you're on?
Maybe
Yeah.
mucosa, because there's no like the top layer is very thin.
Well, we do have a stratum corneum though, don't we? And a granular cell
Yeah.
layer. Okay. I mean, it's possible to be kind of near a mucosal surface, but and here's also a hair follicle. So it wouldn't be a mucosal surface itself, right?
Mm-hmm.
Might be near one.
Yeah. There's some inflammation. And then we
Okay.
thought, yeah, that area to the left was GI mucosa.
GI
Like with the,
mucosa.
yeah. What do
Okay,
you
good, good,
like that villi? Like I think it's like simple columnar, and then there's some glandular tissue there.
good.
And then underneath there's some muscle, all that pink stuff, deeper.
So what's going on here?
So we think it's likely some GI tissue that's very close to the skin.
Okay, good.
So we're thinking could be, we thought the GI features were kind of like duodenum potentially. So maybe like a peg tube site or like an ostomy,
Okay.
or could be like a met to the skin potentially, but it looks pretty like well differentiated and well organized. So I don't think it's like a malignant process.
Okay, good, good. Yeah, I was going to ask you if you thought this might be malignant, and I agree. I don't think it's atypical at all. I think these are just
It looks very healthy.
yes, yes, no mitoses, nothing along those lines. Good. So where in the body do you get this kind of phenomenon? In our field, I mean, if this were maybe in the esophagus, you might think, oh, Barrett's esophagus, where you get GI mucosa kind of going up and replacing the stratified squamous epithelium of the esophagus. But we're not in the esophagus. We're in skin here with hair follicles. So where do we see mucosal epithelium that kind of gets really, really close to stratified squamous epithelium normally in the skin? This isn't normal, though. You're right. I mean, this isn't, there's an abnormality here. This shouldn't be here. But where do we see it normal?
Is it like,
Not,
you don't think,
well,
is
let's
it
say,
like, oh, sorry, go
how
ahead.
about the perianal area, right?
Oh, yeah, yeah.
Perianal verge, you get stratified squamous epithelium, then goes mucosal epithelium, and then if you get, sometimes you'll get like some ectopic, uh, rectal,
Like a hemorrhoid?
colonic
Or,
epithelium. So you sometimes get some sort of like rests of colonic epithelium that get pretty close to the outer edge of the anal verge. So you can see that.
uh-huh, yeah.
And then you mentioned something like an ostomy. Okay,
Mm-hmm.
that's you often get mucosal epithelium that grows into the stratified squamous epithelium from the ostomy site. So it
Mm-hmm.
colonizes, it moves into it, just kind of like a Barrett's esophagus. Well, it does that in the skin also. Sometimes you'll see rests of mucosal epithelium in the mouth, in the oral mucosa. So you can
Mm-hmm.
sometimes it's kind of normally. But this was in the umbilicus area.
Oh, yeah. Was it like a younger patient or?
I think it was actually an older patient.
Oh, okay.
It's been present for a very long time.
Like a hernia or?
Well, it actually is similar to that, yes. This is a Meckel's diverticulum. If you remember that
Oh,
from
yeah.
okay, so it's basically kind of like the mucosal epithelium of probably the ileum or the duodenum gets kind of
Yeah.
like a ectopic focus of that. And so what do you think they were concerned about when they took this biopsy from an adult in this situation? This wasn't a baby. This was an older person.
Like that could be a malignancy?
Yeah, they were
Mm-hmm.
probably worried about that. What malignancy do we often see in this setting in that umbilicus area?
Is it a man or a woman?
Could be either one.
Um, could be like metastatic colon?
Yes. And what's the name of that type of thing when they have a papular or nodular lesion there and they biopsy it and lo and behold, it's actually a malignancy. This wasn't malignant, thank goodness. But when it really is a malignancy, what's that called? What's the term that's used for that finding there? It's a historical term.
Oh, Sister Mary Joseph nodule?
Yeah, good, good. Who was Sister Mary Joseph?
Um, a nun, right?
She
No?
was a nurse. She was, and back in the old days, a lot of these hospitals were Catholic hospitals, and they had nurses were nuns too. They were sisters, and she was a scrub nurse at the Mayo Clinic that was working in the surgery, and she noticed that a lot of these people would come in with these, papular lesion in the umbilicus area. She started just making the observation that that's going to be cancer. It's probably going to kill the patient. And sure enough, when they cut it out and diagnosed it, it was metastatic GI malignancy to the umbilicus. They put her name on it to honor her, Sister Mary Joseph's nodule. So these can be any kind of GI malignancy. Pancreas can go there, colon, stomach, so just about any type of GI malignancy can end up going into this area. Occasionally it's not GI. Sometimes you'll get a GU, like you can get ovarian cancer that can go there or cervical cancer. But probably the most common things that we see are the GI malignancies like this. So this mainly, if they showed this on the board, which they probably wouldn't, they might, want you to kind of go down the pathway of, this is metastatic GI carcinoma because it's in the umbilicus, but no, it's not. This is just basically some Meckel's diverticulum, a persistent ectopic GI tissue that's present in the umbilicus. And all this scar tissue and whatnot, that's probably just the scar from the umbilicus area that we all have. So interesting, um, interesting case for you guys. Yeah, I don't think you'll doubtfully encounter that on the board examination. Now this one you
Thank
could
you.
possibly,
Good morning. I can take this one.
okay?
So here we see a shave biopsy of a what looks like a papule. I was favoring acral location given the compact stratum corneum, pretty eosinophilic.
It's interesting though. Take a look over here.
Mhm.
There's a hair follicle.
Yeah, so I was thinking maybe like dorsum of the hands or feet, the
It's
hands
possible
potentially.
it could be there. It's
Mhm.
possible. I totally agree with that's possible. It's also possible it's an area that may just have been severely traumatized.
Mhm.
A lot of very thick cornified layer, lichen simplex chronicus. So that's another possibility. But I agree. It certainly looks a lot like it's near acral skin or whatever.
Mhm.
Okay.
And then I noticed a lot of inflammation and then some proliferation of vessels. So I was favoring like a benign neoplastic process here. It's
Okay.
overall, generally well localized. And then it's kind of the edges are kind of encompassing the lesion. And I didn't notice significant
It looks like it's
atypia.
kind of almost like it's a little papular lesion. They just kind of shave the whole thing off. I agree with you.
Exactly.
Kind of looks
And
wart, you know. Maybe they thought it was a wart.
right. And then when I got a little bit closer, I noticed a good amount of lymphocytic inflammation in the dermis, the upper dermis, and then a lot of these vessels, a lot of them had like thin walls to them with very regular endothelial cells.
Thin walls?
Some had thin walls, and then some had a little bit of what seemed to be thicker as well.
Okay, good. And what about these endothelial cells here?
They're kind of lining up nicely. They're, kind of plump as expected.
Yeah, on a scale of 1 to 10, these guys need some big time Wegovy. I mean, they're really, really large and plump and protruding into the lumen, which is not normally what we see in our regular endothelial cells, is it? So if we look at these, like this normal capillary up here, look how thin and flat those endothelial cells are. These are normal endothelial cells here.
Mm-hmm.
That's what if I biopsied your skin and we looked at your capillaries, that's what they're going to look like. But this one sitting right next to it is abnormal, and it's got a markedly thick wall too, with these prominent, plump endothelial cells that are protruding. They're shooting into the lumen here, so they're abnormal.
Mm-hmm.
Okay. Anything else?
Some of the vessels seem to be kind of like conglomerated into what looked like lobular structures in
Okay,
some
I'll buy
areas.
that. And you
And
said there's a lot of lymphocytes in here. Any other cell in here?
I was looking to see if I could find a lot of neutrophils, but I didn't think I saw too many. Maybe a few
No, I
EOs.
agree. I don't see any neutrophils either. Maybe a couple of plasma cells. What about these?
Yeah, maybe some EOs right there.
Okay. Any final thoughts here before your diagnosis for our august audience here?
Those are the biggest things I saw. Like my differential I was thinking about with the lobular kind of distribution, like a lobular capillary hemangioma. And
What's the other
then,
name for that? What's the other name
yeah,
for that?
epigenic granuloma.
Okay. You like that? Is that your number one diagnosis?
I would actually favor like a angiolymphoid hyperplasia, given that the different endothelial cells or the plump endothelial cells and the eosinophils as well.
Good. And that's the right answer. That's the answer. So that's good. So when you see angiolymphoid hyperplasia with eosinophilia, first, there's a couple of things. Number one, they don't always have to have very many EOs. Now, I've seen some that have got a gazillion EOs, way more than this, but this has some EOs, so that's good. They actually sometimes will have circulating eosinophils, but not a lot in the tissue, interestingly enough. It's thought to be a hamartoma by many people because of these blood vessels that are abnormal. These are abnormal thick wall blood vessels with very, very thick endothelial cells. I mean, these are not normal blood vessels. So that's part and parcel of the process. In fact, you can make the diagnosis without getting very much inflammatory infiltrate if you see a lot of these blood vessels like this. So that's one thing I really want you to focus on is recognizing these very, very large plump endothelial cells with the very thick walls around them. That's classic for this entity. And then when they have the lymphocytes and the EOs, well, then you're home free, like you made the diagnosis. Now, there's one other item in the differential diagnosis here that you should at least know about. So tell us the clinical scenarios about this. When you so you see this histology, what situation, what do the patients look like when they have this clinically?
I think that they can be like painful or itchy. Typically, I think we see them on like bumps or nodules on the head or neck.
Head and neck area, often around the ear. You said itchy, they got EOs, right? So
Mm-hmm.
maybe that's why it's got this markedly thickened cortified layer, huh?
Right, if they're picking
Like
at
say,
it.
hey, wow, there are EOs in here. They start scratching and boom, they get marked lichen simplex chronicus. It kind of makes it look like a wart, and it's really not that. So that may be why it looks like volar skin, but it's really not. And they usually are seen on the head and neck area, often around the ear. This could be the ear, very, very could be that location. So that's good. And they're red, usually fairly bright red when you see them, or purple. They look like an angioma when you see them clinically. And then what's the other setting, though, where you can see this? So there's certain diseases in dermatology and dermatopathology that we call them histologic identical twins. For example, like Granuloma faciale and erythema nodosa, histologically those look very, very similar. Or bullous pemphigoid and pemphigoid gestationis, those look histologically the same. You know, they're different diseases. In one of them, they've got two different immunofluorescence patterns, but they histologically look the same. So this has got it also has a histologic identical twin, but clinically it's a completely different scenario than just a few bumps on the head and neck area. You know what that disease is?
Is it Kimura disease?
Yeah, good. Kimura's disease. And what's that disease look like? Does it look like just a couple of bumps on somebody's ear?
I think it's a lot more diffuse, like a lot more involvement.
Yes, widespread involvement, exactly. Usually seen in Asian men, can be seen in women too, but I think it was more commonly described in young Asian men, and it obviously from Japan where they originally described it. So just realize that histologically, if you saw this, you couldn't say for sure that this wasn't a patient that had Kimura's disease. Now, there's some other Japanese key diseases that are not Kimura. There's Kitamura's disease. So there's a couple of others. That's one of the more, I think that's one of the kind of reticulate pigmentary anomaly-like diseases, but there's a couple of other diseases, so don't get those confused. But that's the other situation where you see angiolymphoid hyperplasia with eosinophilia histologically. Okay, great. All right. It's a good one.
All right, I can take this one. So
Good.
it looks like we have a pretty deep punch here.
Good.
And there also seems to be inflammation pretty diffusely, like inflammation deep in the subcute area. Just looking at it, it looks benign. It doesn't look like a neoplastic process.
Good. So you think it's inflammatory?
Yes, I do think it's inflammatory.
Okay, good. So what's the pattern? You sort of briefly described a little bit about the distribution of the inflammation. What's the pattern of the inflammation here?
So I think it looks like a paniculitis.
There is
Given
some involvement of the fat, but is it mostly fat involvement?
there's also a lot of involvement in the dermis.
Yeah. I think it's primarily a dermal-based inflammatory process that's spilled into the fat, as opposed to
Okay.
being primarily a paniculitis. But you're right, there is some paniculitis involvement here, so that's fair. But what's the pattern in the dermis that we're looking at here?
Like what kind of cells are involved?
Well, just the pattern. We'll talk about the cells in a second. But what's the pattern that we're looking at here?
Like granulomatous inflammation?
Well,
Or
that's not really a pattern
okay.
per se, right? We talk about the 9 patterns of inflammatory skin diseases, and of course, you know, granulomatous inflammation can give you a lot of different patterns, right?
Mm-hmm.
5 patterns primarily. We won't go through those right now. But what pattern would we call this?
It looks like it's more nodular.
Yeah, good. Nodular and diffuse, right?
Mm-hmm.
Most of the dermis is involved here. It's even getting into the fat a little bit. So it's a nodular and diffuse pattern. So
Yes.
that's good. That's where we're getting it. Now, what kind of inflammatory cells are present?
Mostly neutrophils.
Do you think most of these are neutrophils? There are going to be some in there. I'm going to be willing to bet too. But what do you know?
Maybe.
Power.
It looks pretty light at low power.
Yes, good, very good. They look pale, light. So
Mm-hmm.
what does that make you think about?
More of like a lymphocytic infiltrate.
Well, lymphocytes usually are pretty
Dark
dark.
also.
Power.
Oh, maybe like
They're
more
black.
like maybe like osteocytes or histiocytes or
Histiocytes.
histiocytes.
Good.
Okay.
Histiocytes. And if they're histiocytes that predominate, now what can you say is a type of inflammation?
Histiocytic infiltration
And if we
or
say histiocytes predominate, what do we call that you said it a second ago?
like granulomatous.
Granulomatous. Good, very good. So histiocytes predominate, granulomatous, nodular and diffuse pattern. Okay, and now we're going to higher magnification. Yeah, boy, look at all these histiocytes here. There's a ton of them. And there's some lymphocytes in here. There might be some neutrophils too, right over here. There's some, but there's mostly kind of histiocytes with some lymphocytes, but there are some polys too. Okay, and it's pretty diffuse, like we said before. Okay, so what do you start thinking about when you see this pattern?
Well, I initially thought possibly infectious, given the
Good. You should think infectious.
yes.
Absolutely, you should think infectious. That should be very high on the list when you see this pattern. Absolutely. Notice that it's not sarcoidal,
Right.
right? Not really sarcoidal. It's really more kind of suppurative and granulomatous because there are neutrophils up in this area for sure. So when we see suppurative granulomatous dermatitis, we think of infectious disease. Number one, we also think of, maybe secondary to ruptured cyst or something like that, foreign body. That can also give you suppurative granulomatous dermatitis, but we definitely want to think about an infection. Now, of the infectious diseases, so we're going to think about infections. Is there anything about this area right here that might be potentially a clue to which pathway of infectious diseases you're going to kind of go down?
So I am looking for some blood vessels. I think I see some maybe erythrocytes.
Yeah, this is probably just trauma from the biopsy here.
Okay.
But what about the epidermis? What about this area?
So the epidermis looks like the stratum corneum is like sloughing a little bit.
Well, is
Maybe.
there any major abnormality in the epidermis here?
No, it looks largely normal.
It's pretty normal, yeah. So if you're dealing with an infectious disease that spares the epidermis,
Mm-hmm.
what general infectious diseases tend to do that versus those that like the epidermis, that tend to involve the epidermis?
Yeah, so could be spread like hematogenously, possibly like fungal origin or
Well,
something like it.
so like you're talking about deep fungal, right?
Yes.
Like blasto, sporo,
Yes.
histo. So think of the patients that you've seen with blastomycosis, with sporotrichosis. What do they look like clinically?
Clinically, I mean, their epidermis is intact for the most part.
But it
Um,
doesn't look kind of crusted and they get verrucous
yes.
epidermal
Yeah.
hyperplasia and things like that.
Mhm.
So usually when you're looking at a deep fungal infection, you get suppurative granulomatous dermatitis with pseudocarcinomatous hyperplasia of the epidermis. So you get lots of epidermal involvement, you get abscesses in the epidermis, you get transepidermal elimination of the organisms, like in cocci and sporo and that sort of thing. The organisms kind of get up here and they want to go out. Or if you get a tinea infection, obviously that involves the epidermis. So the clue to this diagnosis is the lack of epidermal involvement. So if you see lack of epidermal involvement, you sort of say that's less likely to be deep fungus.
Deep fungal.
Could be, but it's less likely to be because of that. So what kind of infections can give you suppurative granulomatous dermatitis that don't involve the epidermis as commonly and can give
Um,
you this kind of
could
pattern?
be like a mycobacterium
Yeah, good. An
or
atypical mycobacterial infection. As a
mm-hmm.
general rule, they tend to involve the epidermis less with that pseudocarcinomatous hyperplasia. They still can, but it's less common than the deep fungal infections. So in this case, we stained this and it was positive for a Fite stain. So we didn't include that here because then you'd know the answer. But this was an atypical mycobacterial infection. And this is a more characteristic kind of inflammatory reaction that you get with that. So you wouldn't just know that, without getting additional information. The board's not going to show you this and say the diagnosis is blank. But just so you'll know, when you're looking at one of these and it's an unknown slide and you don't see a lot of epidermal involvement, think that it's more likely to be something like an atypical mycobacterial infection than a classic deep fungal infection here. So this could be swimming pool granuloma. I mean, it could be Mycobacterium kansasii in an AIDS patient, or intracellulare, avium intracellulare. It could be a lot of different things here. And this is probably just secondary paniculitis involvement. And notice that it's mostly a lobular paniculitis. So usually if you do get infectious paniculitis, it tends to be more lobular as opposed to septal. So this was an example of a cutaneous AFB infection. Well, good. But that's the way I want you to work through it. Pattern, type of cell, granulomatous, possibly infectious, and then you notice the lack of the epidermal involvement. you wouldn't waste your time looking for deep fungal organisms here. You may go straight to the Fite stain. All right, very good.
Good morning. I can take this one.
And this one may be a little bit more of a challenge because of the biopsy that we got, but we'll work through it, see what we can come up with here.
Yeah, it felt like a challenge for sure. But this looks like a shave.
Yes.
Hard to tell where exactly it came from. Don't see too many hair follicles. It doesn't look like an acral surface.
Yeah, good. When you get, and that's the most common location for these kind of, for all biopsies is the trunk or proximal extremity. I mean, we certainly would rather biopsy an inflammatory process or even a neoplastic one for that matter, if it's widespread, on the trunk or the proximal extremities, if we can, as opposed to scalp or the, nose or the mucous membrane. So yeah, pretty nondescript skin.
Yeah. Looked like perivascular inflammation, at least superficially, probably deep as well.
Yeah, I mean, and this is a little bit of a pale slide, but did you favor kind of an inflammatory or neoplastic process
I was
here?
favoring more inflammatory for this one.
Okay, good. And you said it's perivascular, but is it only perivascular?
It's kind of perivascular and more diffuse as well.
Great. I think it's fairly diffuse here from what we're looking at. But pale slide, unfortunately, but looks like kind of everything's involved in this field. And unfortunately, they shaved this. Maybe they thought it was a neoplastic process when they shaved it. Maybe it was a papule and probably a sessile elevated papule. So they just said, well, let's just shave the whole thing off. We would have liked to have had a punch so we could evaluate the breadth, apply all of our criteria for the patterns, but we don't have that here. So we'll just live with what we got. What kind of cells did you think were in here?
Looked like several different cell types in there. I
Okay.
think I saw some plasma cells, lymphocytes, some neutrophils.
Okay. What else is kind of going on in this area up in here?
It looked like some interface dermatitis and liquefaction degeneration of the epidermis of the basal layer.
Not only that, but doesn't this thing look really pink and like it might be kind of dead?
It looks kind of necrotic, yes, sir.
It is necrotic, good. And there's even some degeneration of some of the cells down in this area too. A lot of degeneration of collagen. There were inflammatory cells in there once upon a time. They're kind of dead. Let's look over in this area. And now what do you see?
Definitely lots of extravasated red blood cells. Several
Extravasated red cells. And can you make
typical
out,
appearing cells.
what was that again?
I just said several atypical appearing cells.
Yes, good. Good observation there. Let's keep looking. So does that give you any clue to what you might be dealing with here?
Hmm.
I agree. There's a lot of these
Perhaps
cells
something infectious.
atypical. Okay, an infection, possibly. That's one thing. Maybe infection with some reactive atypia. That's one possibility. What about this field right here? This isn't an easy slide. Okay, this is a third year kind of case. So if we were playing a game show, you could dial up a friend or something.
Maybe more vacuolar appearing over here.
Well, notice how you said atypical. Aren't these cells large and a lot of abundant cytoplasm and some of them are hyperchromatic and that one may be bipolar there. And so there's a lot of atypia. And then there's also this necrosis, degeneration of collagen. It's crusted centrally. If we had it's almost kind of got a wedge shape to it. You see that?
Mm-hmm.
Does that give you any kind of clues? What if I told you this process had been going on for a couple of years? These lesions come up and they go away, and then they come up again and go away, and you see them, and they got this black, ugly sort of central necrotic area. And then they've got these papules that are undergoing central degeneration of ulcerating, necrosing, and they're degenerating here. Does that give you any idea, any clues?
Hmm.
Then you do this biopsy, boy, all these atypical, it looks malignant when you look at the cytology, but it's coming and going. Patient
So-
seems to be happily ever after.
Yeah, I guess like things that come and go, something like lymphomatoid papulosis.
Yeah. This is lymphomatoid papulosis. This is an example. This is lymphomatoid papulosis. So this is an example of what these lesions often look like. This is one of the necrotic lesions that you get with lymphomatoid papulosis. And you have to look away from the necrosis to these areas here where you see the atypical lymphoid cells to really make the diagnosis of it. And we would probably, in a situation like this, do a stain. Which stain would we do here? That's the one the board might ask you to do. They might show you this slide, so this is too hard for them to kind of get without any history. And then I show you another picture and they put the label of the stain on it. And they say this the most likely diagnosis is after you saw that stain up there.
Maybe like a CD30 stain.
Yeah, CD30 stain. Yeah, so this is a CD30 positive lymphoproliferative condition. Now there's about, I think they're up to like H now in the alphabet of the different types of lymphomatoid papulosis. You don't need to know all of those. Just realize there's a lot of different subtypes of LYP. There's some types that can kind of look like Mycosis Fungoides. There's a type that can be associated with vasculitis. So there's a lot of different subtypes. There are types with different types of ALK fusions. We talked about ALK a little bit earlier with the lymphoma. So if you get one of these that's got an ALK positive, mutation, you kind of worry about the patient maybe having systemic lymphoma. And then there's a CD30 positive large cell anaplastic lymphoma that histologically can look just like this, but it's one lesion. And some of those are benign and do nothing. Others are, if they have an ALK fusion, they can tend to be more aggressive and can, kill the patient. So anyway, this is a good example of lymphomatoid papulosis. And it's got the degenerated central area. That's classic. These things undergo this infarction, if you will, and they tend to come and go. So good. Tough case, but you'll get it the next time you see it. Now, this was not quite as tough.
Okay, I can take this one. This is a punch. I think the primary process is inflammatory, and
Okay.
we see like a superficial perivascular inflammation. When you zoom in,
Okay.
most of the cells are lymphocytes.
Good.
And
Good.
then for the primary like epidermal change, I think there was like kind of some patchy vacuolar interface, and quite a bit of dyskeratosis as well, in the epidermis. I think there's some extrav of the lymphocytes into the epidermis.
Did you
So
notice any of these kind of cells here?
yeah, these cells with like the kind of the focal clearing around them, I was wondering if I was thinking these might be like lymphocytes.
They are lymphocytes. Yes, they are lymphocytes.
Okay. So my first thought, like kind of going down Ackerman, was maybe like an erythema multiforme or a graft versus host, but with the lymphocytes, with like that clearing, you could also think of Mycosis Fungoides.
Good. Good. What else would you think about?
Mm,
What other diseases do you know that can give you that pattern? There's not too terribly many. Notice the cornified layer, kind of got some broad zones of a little bit of perikeratosis. Now, some of that's from lichen simplex chronicus, but it's abnormal cornified layer too. And you get dyskeratotic keratinocytes, focal epidermotropism sometimes. You often get neutrophils in the cornified layer of a broad front in that disease that can simulate mycosis fungoides.
mm,
You get extravasated erythrocytes in that condition, often seen in children.
are we talking about erythema multiforme?
No, because you get the abnormal cornified layer there.
Yeah.
Erythema usually is basket weave because it occurs quickly. Pityriasis lichenoides,
Okay.
that can simulate MF also. And then
Okay.
drug reactions, drugs, and then certain viral exanthems. So that's kind of about it. There's not a gazillion things that can give you the differential. So in this case, once you that's probably about as far as they wouldn't really expect you to distinguish among too many of those. This is an example of Mycosis Fungoides.
Okay.
It's interesting that it's got the dyskeratotic keratinocytes because that's unusual for MF. I think this patient was actually undergoing light treatment, and they might have actually got a little bit of a light burn that caused some of these dyskeratotic keratinocytes. And these were kind of persistent areas that weren't responding to treatment. So they decided to take a biopsy, and lo and behold, it shows kind of persistent patch stage mycosis fungoides. So that's good that you were able to get that differential. There's a couple other clues that can help you with MF. Sometimes you'll just get the single lymphocytes at the basal cell layer like this. People give that different names, eyeliner sign, whatever you want to call it, but that's a fairly common finding in MF, patch stage MF. Thick collagen bundles with dilated blood vessels, because it's usually a chronic disease. And by the time it's biopsied and the diagnosis is made, you'll usually see some of those abnormal changes in the collagen in the blood vessels. So that's characteristic. And that's often associated with the poikiloderma that you see clinically, with the atrophy and the telangiectasia and other changes. So good. MF, and that's the differential. It's a fairly short differential of things to think about. All right, we can maybe do this last one real quick.
All right, I can do this one.
Okay.
So it looks like we have a shave.
Okay.
I think that this is an inflammatory process.
Good.
I think the pattern is kind of nodular diffuse.
Very good. Excellent. All these nodules, just look at them. Beautiful example of that. Very good. What part of the body?
I think this could be like the face or the head and neck with all the sebaceous glands, some hair follicles.
Very good. Absolutely. And what about the epidermal involvement?
Epidermis looks pretty normal.
Totally normal. In fact, what do we have here?
A Gren zone.
The Gren zone. Good. Good. What kind of cells are in here?
Pretty mixed infiltrate. I saw some neutrophils, lots of EOs, some lymphocytes, some plasma cells.
So what's the diagnosis?
I was thinking this was Granuloma faciale.
Good. It's pretty classic for that, isn't it? It's beautiful. And they're going to show you something like this if you get this on the board examination. Now, see if you were listening to me earlier. What looks exactly like this under the microscope, but it isn't Granuloma faciale?
EED?
Okay, good. Yes, that's the histologic identical twin of this condition. It looks almost identical to it, but it's not on the face. So if you see this pattern on the face, it's Granuloma faciale. If you see it on the hand, it's EED. Now, what else can you often see in this condition that we're not seeing quite as much here, but there's two other findings that we'll often see in Granuloma faciale. You got a little bit of that right over here.
Like a leukocytoclastic vasculitis.
Yeah, it's basically kind of a nodular variant. It's not, nodular vasculitis like erythema induratum, but it is nodular inflammation with vasculitis. And you'll often sometimes you'll see fibrin sometimes in the wall of blood vessels. If you see really an early case of ED, and I've seen this before when it was at the very earliest stage, it showed classic LCV, and then it evolved into this pattern of nodular lesions with eventually the perivascular fibrosis when the lesion's been present for a long period of time. You don't get as much of that perivascular fibrosis in GF as you do in EED. EED, you also extracellular cholesterol clefts, so it's a little different than GF, but histologically they look pretty much the same. The only other item that might get tossed out in the differential diagnosis might be pseudolymphoma, but you don't usually get neutrophils in that. You don't get nuclear dust in that. You do get germinal centers, and you usually don't get germinal centers in this. So you can tell it apart from the pseudolymphoma most of the time. So that's Granuloma faciale. Okay, good job, guys.